Okay. Usually I kick things off by, introducing a topic and saying we're going to explore it. But today feels different.
It is
I
different.
mean, this stack of books you've put in front of me, Miller's, Katie Tripathi, Guyton, this looks less like a deep dive and more like an interrogation.
That's the idea. Today, I am not your co-host.
We're not.
I am your senior faculty examiner for the Gujarat University MD Anesthesiology Finals, and you are my postgraduate student.
Oh, wow. Okay, so the pressure is on.
The pressure is absolutely on because our topic today, prostaglandins, is a classic.
A classic trap, you mean?
A classic trap. It's the 20-mark long answer question that makes or breaks a paper. It's a minefield in the Viva. If you don't get this, you don't get inflammation, you don't get pain, and you certainly don't know how to protect a kidney in the OR.
I'm swaying a little already. But I've done the reading. I think I'm ready.
Yeah.
So we're diving into prostaglandins, their synthesis, classification, physiological actions, and most importantly, the clinical and anesthetic applications.
Exactly. And we'll structure this precisely like an exam answer. Part A, basic science. B, physiology. C, clinical use. And D, anesthetic relevance. This is a drill. I need precision. I need mechanism.
Out it.
Let's begin. Part A, introduction. Define the subject. What are prostaglandins?
Okay, so prostaglandins are biologically active lipid compounds, but they're not really hormones in the classic sense. In an exam, I would call them autocoids.
Stop! Define autocoid. The examiners love this. It shows you understand the fundamentals.
Right. It's from Greek. Autos means self, and akos means remedy, so a self-remedy.
And what does that mean functionally? Why is that different from a hormone?
Because a true hormone, like, say, thyroxine, gets made in the gland, dumped into the blood, and travels a long way to its target. It's a systemic signal.
A broadcast.
A broadcast, yeah.
Uh-huh.
Autocoids are local. They're paracrine or autocrine. They're made where they're needed. They act right there on the cells next door, and then they're gone.
Perfect. Think of a hormone as a citywide radio broadcast. An autocoid is a text message sent to the person next to you. It doesn't leave the room.
That's a great analogy.
And chemically, what family do they belong to?
They are eicosanoids.
You knew.
They're all derived from 20 carbon fatty acids. The name comes from the Greek eikosa for 20.
Good. And they're based on a parent structure called prostanoic acid. Now, how widespread are they?
Oh, they're ubiquitous. I mean, pretty much every cell with a nucleus can make them. The big exception is the red blood cell.
Correct. So to frame this for an examiner, why do we, as anesthetists, care so much about them?
Because they're the local managers of everything. Inflammation, blood flow, clotting, labor. And we're constantly messing with them. Every time we give an NSAID, we're inhibiting them. Every time we manage a PPH, we're using them.
Excellent framing. All right, let's move on. Section 2, biosynthesis. This is extremely high yield. If you can't draw this pathway, you fail the question. Simple as that. Walk me through it. Where does it all begin?
It all starts in the cell membrane, in the phospholipid bilayer.
Okay. Yeah.
When there's a trigger trauma, cytokines, ischemia, anything like that, an enzyme called phospholipase A2 gets activated.
Good. And this is our first clinical checkpoint. What major drug class acts right here at the very top?
Corticosteroids.
Ah.
They induce the synthesis of proteins, lipocortins, or annexins, which inhibit phospholipase A2.
Exactly. This is why steroids are such powerful anti-inflammatories. They cut the whole cascade off at the source. They stop the precursor from even being released. So PLA2 releases this precursor. What is it called?
That's arachidonic acid, the 20-carbon fatty acid.
Good. Now, this arachidonic acid is at a fork in the road. It has two main metabolic paths. What are they?
It can go down the lipoxygenase pathway, which makes leukotrienes.
Which we will come back to when we discuss asthma.
Right. Or it can go down the pathway we care about today, the cyclooxygenase, or COX, pathway.
The COX pathway. This enzyme takes arachidonic acid and forms unstable intermediates, the cyclic endoperoxides, PGG2, and then PGH2.
Right, they're very short-lived. And then from PGH2, you get all the different active prostaglandins, depending on which synthase enzyme is in that specific tissue.
Before we get to the products, let's talk about the factory, the COX enzyme. It's not one thing, is it? Tell me about the isoform.
No, there are two main ones, COX1 and COX2.
This is the classic Viva question. Differentiate them for me. Give them a character.
Okay, so COX1 is the constitutive one. I think of it as the housekeeper. It's always on in almost all tissues. It's doing the day-to-day work, maintaining homeostasis.
Such as
producing the prostaglandins that protect the stomach lining, maintain renal blood flow, and help platelets stick together. It's the good guy, just keeping things running.
And TOX2?
TOX2 is the inducible one, the troublemaker. It's usually not present in most tissues. But, when there's an injury or inflammation, its expression is massively upregulated. It's the one that produces the huge flood of prostaglandins that cause pain, fever, and inflammation.
An excellent distinction. But is there a catch? An exception to the rule?
Ah, yes, the exception. COX-2 is actually constitutive, so it's normally present in a couple of places.
Yeah.
The brain and the kidney, specifically the macula densa.
Very good. That nuance gets you full marks. Okay, let's classify the end products. From PGH2, we get what we call the 2-series prostanoids. Why the number 2?
Because they have 2 double bonds in their structure, which comes from the original arachidonic acid. And this is the main series in humans.
List the key members of this family.
Okay, we have PGE2, PGF2 alpha, PGI2, which we also call prostacyclin, and thromboxane A2, or TXA2.
Good. Now let's group them functionally. How would you present this in an exam?
I'd probably make a small table. You have the PGE series, mainly PGE2. Its big things are vasodilation, pain sensitization, and fever.
Okay.
Then the PGF series, PGF2 alpha. Remember, F for forceful. It causes constriction, bronchoconstriction, vasoconstriction, and forceful uterine contractions.
And the other 2?
The other 2 are kind of special. They're antagonists. You have prostacyclin, PGI2, and thromboxane, TXA2. We're going to put a pin in those 2. Their balance is so critical, it deserves its own section. Let's move to Part B, physiological actions, connecting the science to the body, system by system. Let's start with cardiovascular.
Okay, in the blood vessels, it's a balance. PGE2, and especially prostacyclin, PGI2, are potent vasodilators. They relax smooth muscle, blood pressure drops.
And on the other side?
On the other side, you have PGF2 alpha and thromboxane A2. They're vasoconstrictors.
What about the platelets themselves?
On any
in the blood.
This is that classic yin and yang balance. Thromboxane A2 is made by platelets, and it makes them aggregate. It's pro-clotting.
And its opposite
is prostacyclin, PGI2. It's made by the endothelium, the lining of the blood vessel, and it powerfully inhibits platelet aggregation. It's anti-clotting.
Good. Respiratory system. Why do we get nervous giving certain drugs to asthmatics?
Because of this balance again. Airway tone is a tug-of-war. PGE2 is a bronchodilator. But PGF2 alpha and thromboxane are very potent bronchoconstrictors.
So in an asthmatic, the airway is already twitchy, and if you tip that balance toward the constrictors, you can trigger a severe attack.
Correct. Now, the renal system. This is critical for us. If you get this, you'll save a lot of kidneys perioperatively. Explain their role.
So this is really interesting. In the kidney, prostaglandins, mainly PGE2 and PGI2, are made locally. They act as vasodilators, but specifically, they dilate the afferent arteriole, the vessel going into the glomerulus.
And why does that specific location matter so much?
It's all about stress. Under normal, calm conditions, they don't do all that much. But during surgery, or if a patient is septic or hypovolemic, the body's stress response kicks in.
The sympathetic nervous system and RAS.
Right, and they cause systemic vasoconstriction to maintain blood pressure. That includes constricting the renal arteries.
But the kidney needs blood flow, so...
So the prostaglandins act as a local rescue mechanism. They fight back against the systemic noradrenaline and angiotensin II. They hold the afferent arteriole open, ensuring the glomerulus still gets perfused, even when the rest of the body is clamping down. They preserve RBF and GFR.
A brilliant explanation. It's a local protective buffer. So now answer the million-dollar question. What happens if you give an NSAID to that stressed hypovolemic patient?
You take away that protective vasodilation. The afferent arteriole now has no defense against the sympathetic onslaught. It clamps shut. GFR plummets. And the patient goes into acute kidney injury.
That is the mechanism of NSAID-induced renal failure. It is purely hemodynamic. Beautiful. And briefly, the GI system.
Cytoprotection, the stomach shield. PGE2 and PGI2 tell the stomach to make less acid and, more importantly, to make more protective mucus and bicarbonate.
Which is why chronic NSAID use leads to
peptic ulcers and GI bleeds. You've taken away the stomach's armor.
Good. Let's talk pain and inflammation. Do prostaglandins actually cause pain?
Not directly, no. They don't fire the nerve themselves. What they do is they sensitize the nociceptors to other things, like bradykinin or histamine. They lower the pain threshold.
So they cause hyperalgesia.
Exactly. A stimulus that should just be a touch now feels like a burn.
And fever, where does that happen?
That's a central effect in the hypothalamus. Pyrogens, like IL-1 from an infection, cause PGE2 to be made in the hypothalamus. That PGE2 then resets the body's thermostat to a higher level.
And the body responds how?
The body now thinks 37 degrees is cold, so it starts shivering and vasoconstricting to generate heat and reach the new higher set point.
And how do NSAIDs like paracetamol work on fever?
They cross the blood-brain barrier and block that specific PGE2 synthesis in the hypothalamus, allowing the thermostat to reset back to normal.
Perfect. Your basic science is solid. Now let's move to the wards. Part C, clinical and pharmacological importance. We'll start with obstetrics, a definite exam favorite. How are we using these drugs in the labor room?
Well, the most common use is for induction of labor. We use PGE2, which is called dinoprostone. It comes as a gel or a pessary.
And it does two things, right?
Right? It directly causes uterine contractions, but it also ripens the cervix by breaking down collagen, making it soft and ready for delivery.
Good. Now the baby is delivered, but the uterus is boggy and bleeding. Postpartum hemorrhage, oxytocin isn't working. What's next?
Next up is a prostaglandin. We use Carboprost or Hemabate. It's a derivative of PGF2-alpha.
PGF2-alpha, and what does it do?
It causes a massive, powerful tetanic uterine contraction. It clamps down on those bleeding spiral arteries and stops the hemorrhage.
Okay. Here is the Viva trap. The obstetrician is shouting for Carboprost. You, the anesthetist, glance at the patient's chart and see a history of severe asthma. What do you say?
I say no, absolutely not.
Why?
Because Carboprost is a PGF2-alpha analog. And as we just discussed, PGF2-alpha is a powerful bronchoconstrictor. Giving it to an asthmatic is asking for a catastrophic, life-threatening bronchospasm. It is contraindicated.
That single answer could save a patient's life, so what do you suggest instead?
I'd suggest misoprostol. It's a PGE1 analog, still causes strong uterine contractions, but without that dangerous bronchoconstrictor effect.
Excellent clinical reasoning. Okay, let's move to the ICU and the cardiac OT. How do we use PGI2, prostacyclin, therapeutically?
For pulmonary hypertension, the drug is epoprostenol, which is synthetic PGI2, or its cousin, iloprost. We give it as an inhaled agent.
Why inhaled?
Because that targets it directly to the pulmonary circulation. It causes selective vasodilation of the pulmonary arteries, which lowers the pulmonary vascular resistance and takes the strain off the right heart.
And what about systemic blood pressure?
That's the beauty of it. It has a super short half-life, so it gets metabolized in the lungs before it can escape into the systemic circulation. So no systemic hypotension. It's a magic bullet for right heart failure, or ARDS.
Very well put. Now, congenital heart disease, ductus arteriosus, what keeps it open in the fetus?
Prostaglandins, specifically PGE2.
And after birth, prostaglandin levels fall, and it normally closes. But what if we need it to stay open?
In certain ductal-dependent heart lesions, keeping that duct open is the only thing keeping the baby alive until surgery. So we give a continuous infusion of PGE1, Alprostadil, to keep it patent.
And the opposite scenario, a premature neonate with a patent ductus arteriosus that's causing problems and needs to be closed.
We do the exact opposite. We give an NSAI, like indomethacin or ibuprofen,
To do what?
to inhibit COX, stop prostaglandin synthesis in the wall of the ductus, which removes the keep open signal and allows it to constrict and close.
Perfect. It's a switch we can flip either way. Now let's drill down into that platelet balance. Section 8, the aspirin story. This is core knowledge. Why is a tiny dose of aspirin so effective as an antiplatelet agent while ibuprofen isn't used that way?
It's all about the type of inhibition. Ibuprofen is a reversible inhibitor. It just sits in the COX enzyme's active site for a while and then leaves.
But aspirin?
Aspirin is different. It causes irreversible acetylation. It forms a permanent covalent bond with the enzyme and destroys it for good.
Okay, but it destroys the enzyme in both the platelet and the endothelial cell, so why does the anti-clotting effect win?
Because the platelet has a fatal weakness. It has no nucleus.
And therefore?
It can't make new proteins. So when aspirin kills its COX-1 enzyme, that platelet is crippled. It can never make thromboxane again for its entire 7 to 10 day lifespan.
But the endothelial cell...
The endothelial cell has a nucleus. It's a proper factory. It just says, okay, that enzyme is broken, and synthesizes a new batch of COX within a few hours. So it recovers its ability to make the anti-clotting prostacyclin.
So the net effect of low-dose aspirin is...
You get a long-lasting, profound drop in the pro-clotting thromboxane, while the anti-clotting prostacyclin is relatively spared. The whole balance of the system is shifted towards antithrombosis.
That is a perfect explanation. Now, use that same logic to explain the problem with the selective COX-2 inhibitors, the COXIBs. Why did they turn out to have a major cardiovascular risk?
It's the same logic, just flipped. We thought they were great because they spared COX-1, so no stomach ulcers.
Right.
But it turns out that endothelial prostacyclin production, the good guy, is partly dependent on COX-2. Meanwhile, platelet thromboxane, the bad guy, is pure COX-1.
So if you give a coxib,
You inhibit the good anti-clotting prostacyclin, but you leave the bad pro-clotting thromboxane completely untouched and unopposed. You've just created a pro-thrombotic state.
which leads to an increased risk of MI and stroke.
Exactly. You see how understanding the basic pathway predicts these huge clinical outcomes?
It really does. It all clicks into place.
That's the goal.
Yeah.
Okay, final section. Part D, anesthetic relevance and exam integration. We're in the operating room. Let's talk about the triple whammy for the kidneys.
Okay, the triple whammy. This is when a patient is on 3 drugs that all hurt the kidney in different ways. An ACE inhibitor,
Which dilates the efferent arteriole.
a diuretic, which makes them volume depleted,
Yeah.
and NAAA, which we now know constricts the efferent arteriole. The combination just crushes glomerular filtration from all sides.
So the take-home for us is,
Be incredibly wary of giving perioperative NSAIDs like Curelac to elderly patients on these drugs, or to anyone who is even slightly dehydrated.
good. Bleeding risk. What's our main concern as anesthetists?
Well, surgical bleeding is one thing, but the real nightmare scenario for us is with neuraxial blocks, spinals, and epidurals.
Because if platelet function is impaired, and you put a needle in that space, you risk causing an epidural hematoma, bleeding in the spinal canal, which can compress the spinal cord, and cause permanent paralysis. So we follow the ASRA guidelines on timing very, very strictly.
We do. Now, respiratory. A patient has asthma and nasal polyps. They need pain relief. Can you give them diclofenac?
Absolutely not.
Yeah.
That's Samter's triad or aspirin-exacerbated respiratory disease.
Is it an allergy?
No, it's not a true IG-mediated allergy. It's a shunting mechanism.
Explain.
If I give an NSAID, I block the KOX pathway. All that precursor, the arachidonic acid, has nowhere to go. So I get shunted down the other path, the lipoxygenase pathway.
And that leads to a massive overproduction of...
Leukotrienes, and leukotrienes are 1,000 times more potent as bronchoconstrictors than histamine. It triggers a violent asthma attack.
Correct. Okay, quick fire round. A short note on the adverse effects of NSAIDs. Go.
Okay. GI, peptic ulcers, bleeding, renal, salt and water retention, edema, hypertension, hyperkalemia, and AKI.
Good. You remembered hyperkalemia. Why does that happen?
It's because prostaglandins are involved in renin release. You block them, you get less renin, less aldosterone, and you retain potassium.
Excellent detail. Keep going.
Respiratory, bronchospasm in susceptible patients, cardiovascular, increased thrombosis risk with COX-2 inhibitors, and platelets, bleeding dysfunction.
Very comprehensive. Another Viva trap. Is paracetamol an NSAI?
No. I mean, not really. It's
Yeah.
different. It's a great analgesic and antipyretic, but it has almost no peripheral anti-inflammatory effects.
So where does it work?
The mechanism isn't fully clear, but it's thought to be mainly central, maybe a COX-3 variant in the brain or something to do with the cannabinoid system. The key is it doesn't cause the classic peripheral side effects like ulcers or bleeding.
Correct. It's in a class of its own. Okay, last part. Exam presentation. You're in the hall. You've got the 20-mark question. How do you structure the answer on the page?
First, definition. Then, immediately, I draw the diagram.
Describe the diagram for me.
Cell membrane at the top. Arrow down, labeled phospholipase A2, pointing to arachidonic acid. I put a big X on that arrow and label it corticosteroids.
Good.
Then arachidonic acid splits. The left fork is the COX pathway, and I put another X on that arrow labeled NSAIDs. That leads to the prostanoids. The right fork is the lipoxygenase pathway to leukotrienes.
A good, clear diagram is worth 5 marks on its own. What's next?
A table classifying the prostaglandins, then systemic effects, heading by heading, CVS, renal, GI, and so on. Then clinical uses, again with headings for obstetrics, ICU, etc. Then a dedicated section on anesthetic implications. And a conclusion.
And what would that conclusion say?
Something like, prostaglandins are essential local mediators of homeostasis and inflammation. Their synthesis and balance are critical for everything from gastric protection to renal perfusion. As anesthetists, our interventions, especially with NSAIDs, constantly interact with the system. Therefore, a thorough understanding of the pathways, specifically the balance between KOX-1 and KOX-2, and between prostacyclin and thromboxane, is fundamental to safe anesthetic practice.
Excellent. You've linked the biochemistry to the physiology to the clinical practice. That's an MD-level answer. You have passed this drill.
Thank you. That was intense, but it really helped solidify everything. That whole renal physiology part, the afferent arteriole fighting to stay open, that image really makes the danger of giving ketorolac to the wrong patient stick in your mind.
It should. Anesthesia is just applied physiology. Always remember that. One final piece of advice. In the real Viva, if you get lost, go back to the pathway diagram, draw it in your mind. Every action, every side effect can be traced back to that diagram. It's your anchor.
I'll remember that. Thank you.
You are ready.
Well, thanks. And to everyone listening, whether you're facing your finals or just wanted a refresher, thank you for diving deep with us. We'll see you on the next one.